So welcome back, everyone. The conference is restarting now. It's 11:55 UK time, 12:55 Central European time. I hope you had a nice break. And I get now to introduce the final session, which addresses the absolutely key issues of how do we treat long COVID, how do we rehabilitate people with long COVID, and how do we support people with long COVID. And so I'll pass on now to Marianne to introduce the first part of this session.
I would like to say welcome back after the break. We will start session 3 now, where we will talk more about treatment and rehabilitation and support. First of all, we would like to show another video of the 2 patients we met earlier, Malou and Natalie, where they will talk about their experience about treatment.
So I think around 2 to 3 months, it still wouldn't go away. It's like a flu that never goes away. You wake up and you hope, oh, is it getting any better? And it's not. I called the doctors and they said, well, just keep still. And yeah. And after maybe a week or something, I was talking to a supervisor who used to be a doctor before she was a psychotherapist. And she looked at me and she said, oh, you really have problems breathing. Maybe you should check in the hospital or call there. And I went there, and but my saturation was fine at that moment. So they just sent me home again. And I was terribly ill for 6 weeks or something.
Without being arrogant, because I'd been part of this community and was actively researching and was listening to people who I kind of respected in terms of what they were saying, and it was all aligning, and was hearing about people's like quite negative experiences with some GPs, but also being aware that GPs just weren't ready for that. How were they to know what it was, how it was going to present? They didn't. They're not long COVID experts.
And I read everything on Facebook and in papers, but there was not really medical treatment. I called the doctors, the family doctors, 3 times, but they didn't really have good advice. They told me I did too much. I didn't do anything. So it was really difficult to do less than I did.
I'm lucky that I had a really good doctor who I dealt with a few times throughout this, and also latterly when I had an experience of quite awful vertigo and labyrinthitis, which I think was a byproduct of long COVID. And she's just someone who I really respected, and she respected me, and she kind of knows of me because of my background in perinatal mental health. And she was listening to me and she said, yeah, it sounds to me like you might know quite a lot about this. You could even tell me some stuff about what you're hearing from the groups. And I thought, that's great. We need to be sending our GPs the latest insights so that they can be sharing it in the clinical world, obviously where it's validated information.
I had to go over my boundaries. I had to, because they want to test it. And then I had a really bad, for 6 weeks. And after that, I improved little bit by little bit, a little bit. So it helped me to look in months, because you don't feel any improvement in 1 month. But if you look back in, hey, what could I do a month ago, or what could I do 3 months ago, then you do see that you are getting little bit better every 3 months. It just goes very slow. So it takes time to to accept that you have to be really patient with your body, and that not everyone will understand you.
I think for some people, the psychological impact of it is greater than the physical, and the physical is pretty intense. So that gives you some degree of perspective on it. And I know for a fact there are a lot of people who are struggling with quite deep depression at the moment and anxiety. I've become way more present with what's just unfolding now and less preoccupied about how's this going to look in 3 years' time. Well, who knows? I'm just grateful to be alive now, to be honest with you, and that's a good thing.
I have ADHD. I'm going in bam 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 fast lane. So I was really working a lot, studying a lot, being here, there. So I cannot do it anymore at this moment, but I don't know if I want to also. So I at this point, maybe sometime it will kick in again that I want to do another something, but this moment I want to just relax.
So I think we have to say a big thank you to Marlu and Natalie for sharing their stories, very powerful stories of having long COVID, and now their experiences of treatment and trying to access treatment. And so we're moving on in session 3 to talk about that in more detail. And it's now my absolute pleasure to welcome back Danny Altmann, Professor Danny Altmann from Imperial College in London, who's going to give us the presentation on treatment of long COVID. Danny, welcome.
Thank you. So people will have gathered, I'm an immunologist. I work at Imperial College in London, and I want to take a few minutes to talk about long COVID. What do we know? What do we need to know? And how does this lead to future treatments? So I know we have people on this call from many different countries. I'm speaking from the United Kingdom, where there was quite a sort of rapid move into long COVID clinics, although perhaps not always with the results that we hoped for, despite heroic efforts. But if we're talking about what kind of meaning clinical support could we get or do we want from long COVID clinics, some of the obvious questions to think about: who will refer you there? How will you get there? What kind of diagnostic certainty will you need to arrive there? What clinical specialties will sit in them? We've already talked, and we'll talk some more about how incredibly multi-system this disease is. And if we're talking about many millions of cases across the world, who are these staff and where will they come from, and where and when will they have been trained? And when these people are sitting in their long COVID clinic, what will be in that clinic? What specialist equipment will they need? What tests will they apply to work out what's wrong with you? And how to deal with the fact that a person's symptoms may relapse and remit and move between needing the support of a rheumatologist or a cardiologist or an endocrinologist, or you can see what I'm getting at here. And if you put all of that together, how is this person going to work out what type of management, what kind of therapeutics, what kind of medicines will help the person in front of them? And the big scary question that we all worry about: how many years do we need to plan these clinics for? Certainly, in the UK, I think there's no particular long-term planning about it at all. And of course, we don't know whether this is a 1-year question, a 5-year question, or more. So I was asked to talk about treatment now and in the future, but I'm not terribly good at following instructions. But also, more than that, I didn't really want to get into that kind of Donald Trump kind of territory of rumors I've heard from my friends of things that have worked, or pouring bleach down people's lungs, or whichever one it was that he liked. So rather than talking about things I know that friends have got to work, I thought I could give a more usefully a kind of general talk about where the answers come from and what kind of answers we're after. So I hope that's helpful. So many months ago in the British Medical Journal, I got together with Rosemary Boyden, and we put down our kind of manifesto, really, of what we thought was needed to try and advance understanding of long COVID and treatment of long COVID. And to summarize of the, by all means, I'd be very pleased if you go away and read the article, but to summarize what we said, we felt at the time very frustrated that there was a lot of counting lot of counting of cases, but not much doing. And I think we had the line in it that we had to move from the observational to the interventional. And of course, moving from observation to intervention implies that you know how to intervene and that you have some kind of rationale for your intervention to actually do something useful. So in a sense, that's what the rest of this talk is about. So as I said, I'm speaking from the United Kingdom, and people may be aware that here what's happening is that there's a lot of debate and a lot of controversy at the moment about government policy, where there's talk about a kind of tolerance for ending our measures to limit COVID-19 cases, accepting that we'll move into a phase very rapidly where we'll have 100,000 new COVID-19 cases per day. And implicit in that depending on the figures, that we'll have something like 10 to 20,000 new long COVID cases per day. And because of the demographic of where those cases are spreading, that'll be particularly within our secondary schools and our universities. Sorry, I seem to have jumped. Hang on. That'll be particularly within our secondary schools and universities. And as I alluded to before, I think we're almost scared to address the enormity of the questions, because this really does have implications for our society, for our healthcare provision planning, for education, and certainly, again, trying not to be political here, but questions almost too big for our politicians to be able to address in the heat of battle. So we've seen many versions of this in the last few hours, so I won't dwell on this. This is one of the versions that I like of the symptom profile. It comes from a very good paper from another long COVID sufferer, from Hannah Davis and her colleagues at University College. But it makes the case, as you've seen in other people's slides, that you all know very well, that this is diverse and variable and multi-system and multi-organ. So let's agree on that and leave it at that. So how can I, as a professor of immunology, do anything to help to narrate the story, the pathophysiology of this massive phenomenon of a variable, fluctuating, relapsing and remitting set of symptoms affecting almost every part of the body? Yeah. So I think I mentioned before that try and see it from both sides of the table. Try and see both the devastated, desperate, impatient patient who's just had enough. So you're on the one hand, you might be on one side of the table, you might be the desperate patient just really thinking, why won't anybody give me any answers? Or you might be on the other side of the table, you might be the junior doctor who's been told by your consultant that you're now in charge of the long COVID clinic, and you don't know what long COVID is. You were never taught anything about it in medical school. There's been no chapter on it in your general internal medicine textbook, and you haven't got a clue. All you see is a very, is panicked people on both sides of the table. So let me give you a metaphor from another disease, which I hope you won't find it labored. You might find it helpful. So imagine you are now that junior doctor sometime in the past, and you're sitting in your clinic, you're now the doctor, and a young woman comes in to see you, and the first time she comes to see you, she complains of breathlessness and wheezing and respiratory problems. And the next time she comes to see you, she's worried about her hair loss and her high fevers. And the next time she comes to see you, it's about her painful joints. And then another 3 months goes by, and she's got a whole new set of problems to do with her kidneys and blood in her urine. And another 3 months goes by, and you wonder what on earth is going on, because this time it's all about the rash on her face. And how can so many different things be going on? And is she really ill? And if so, what with? Or maybe she's just some kind of hypochondriac or attention seeker. And many people will have realized that what I'm talking about here is a person with lupus So I hope you can see that the metaphor is of some value, because one disease process, one molecular mechanism, and all these different parts of the body affected. But if you missed that textbook chapter and didn't know the cause, you might think it was a crazy person, who had all these sort of different things apparently wrong with them. And so in the case of a disease like lupus, it's taken a very, very long time to decode the story. If you sort of eyeball this timeline from a paper about the history of lupus, over the last 1,500 years, we've gone from little understanding of the phenomena, and the cure was going to visit the shrine in France, to modern medicine, where there's a very good molecular medicine explanation of lupus as an autoimmune disease, and we'll come back to that in a moment. And so over the last 40, 50 years of appreciating that it's an autoimmune disease, where almost a single step, a faulty immune response, making autoimmune antibodies to parts of your DNA and proteins complex to your DNA, can lead to all of these diverse disease processes. Okay, so if I try and fast forward from that and think, well, if it took us 1,500 years to get that far on lupus, how are we going to fast track that into hopefully a year or less of research in long COVID? We've had various discussions of this before, but the kind of hypotheses that our lab put forward and others, both in that BMJ article and in the World Health Organization document, are all of the obvious, really. The thing that Betty mentioned about how many ACE2 positive cells in many organs in the body are affected, and there may simply be the thing that you see on MRI or on CT scans, scarring and fibrosis in different tissues, that hopefully gets better with time. A lot of interest in a coronavirus doing something it was never meant to do in the textbooks, that's setting up a kind of long-term persistent reservoir of infection. A lot of interest and some evidence for virus being present in the long term in the gut. And you can do that in different ways, both by looking at people who are being investigated, because of things like their inflammatory bowel disease anyway. Or the other trick that we like is simply getting a poop sample and using a PCR to amplify virus out of poop, and showing that many people do have it there persistently. What we don't yet know is whether that's a specific correlate of long COVID, or just something that happens in some people after COVID. Oh, sorry, I've jumped again. We'll talk about another hypothesis, that acute viral infections cause immune subsets, and we'll talk about that in a moment, to be perturbed and dysregulated. And then the last hypothesis that I'm rather keen on, and we and others have some evidence for, that we can think about long COVID as an autoimmune response, a bit like the example I gave from lupus. So let's explore some of those things. So I've now used the term autoimmunity quite a lot, and we all, I guess, vaguely understand what we mean by that, but just to kind of home in on it. So for folks like me, the immune system is a wondrous thing. It's not just a sort of single type of white blood cell. It's many thousands of different types and subsets of white blood cells that do things all around your body and obviously make products. The best known one are the antibodies. And the reason that they have such an enormous evolutionary value for all species is that they're the way that we fight unwanted invaders, whether it's viruses or bacteria or fungi or cancer cells. And we also have known for a long time that this very complex regulated immune program sometimes goes awry, so that instead of recognizing foreign targets, the jargon name for that is antigens, they start to recognize antigens on human cells, on your own cells. Examples like recognizing joint antigens leading to arthritis, or the myelin sheath of neurons leading to multiple sclerosis, or the cells that make insulin leading to type 1 diabetes. And the reason I think it's useful to know this and think about it in this way is that I think it does lead us to answers and therapeutics, because recent decades really have been a kind of golden age for autoimmunity research and for translating that research into understanding of mechanism and into many, many newly licensed drugs that have made a big difference to people. So you can see my direction of travel here, that if we could tell this story better, we could do things for people. So in the past, we've known of many examples where virus infections lead to long-term symptoms. And for my taste, if we can learn from these and define molecular mechanisms, we can design precise diagnostic tests for health service use. And for all the reasons we've discussed this morning, that in itself would be a valuable thing, I think, because then people start to have a clear, unequivocal diagnosis that they can take to their hospital, to their doctor, to their employer for that matter, and start to negotiate what's going to happen next. But it's not just that, is it? Because if you knew, again, by analogy to any of those autoimmune diseases, what was causing it, you can then turn to that vast toolkit of goodies we've got for treating autoimmune diseases and begin to look at what one can do to get rid of those the symptoms. We've talked about some of these things. So we know the evidence for fibrosis. We've seen the MRI changes and CT changes, and we've seen the evidence that some people have persistent virus in their guts and in their poop. So just to tell the story of some of the bits of evidence from some of those other virus infections I was talking about. So one of the quotes that I've used, probably overused, is that acute viral infection can be like throwing a hand grenade into the immune system, dysregulating the normal immune subsets. One of the best examples of this that I've ever seen is glandular fever, the way that Epstein-Barr virus infects often young people, and they get glandular fever or infectious mononucleosis. And many of them are not just laid low by the acute infection, but it can take them years to get back to normal in terms of their state of health, their susceptibility to other infections. And there's an immune system explanation for that, because their immune system really has been hijacked here in terms of a kind of T cells called CD8 cells. Here's another example from another infection that's been mentioned today already, Ebola virus infection. We all know that Ebola causes acute disease and death from a kind of hemorrhagic illness. What I think fewer people know is that even among the survivors, there's a really high prevalence of, the kind of things that'll be familiar to you, headache, joint pain, muscle pain, memory loss, and a lot of work ongoing to try and understand that. So that's two examples from quite diverse viral infections. Here's one of my favorites. Our lab does a lot of work in Brazil. We work on an infection spread by mosquitoes called chikungunya. The reason I bring up this analogy is because, again, it's not just the acute infection that troubles people, which is looks a bit like dengue or Zika. It's a fever and a rash. It's the fact that a sizable minority of people go on to get an autoimmune arthritis, and that devastates them. It puts them out of work, it puts them out of the economy. It also, in countries that are affected widely by it, like Brazil, affects pressure on the healthcare system. So you can see why I kind of bring up these examples. So these are the kind of examples that certainly in my lab and other immunology labs are informing the research that we're doing, working with people who have long COVID, to try and understand what on earth it's all about, therefore, and thus, what we can do for people. And to finish, this is an example of the kind of work, not from our lab here, but from Yale, from Akiko Iwazaki and Aaron Ring. And so this thing that looks like a kind of starry night, every time there's a dot lit up as a color, that's an antibody that bound to a human protein, in this case, either from central nervous system or from the from the vascular lining, showing you how, as a consequence of COVID-19, a whole new array of autoimmunity can be set up. And our mission at the moment, and I think the same in some other labs, is to try and tell that story and work out which autoimmune profiles could be responsible for long COVID, which we think will lead us to diagnostic tests and to therapeutics. So I think that's my last slide. So I'll end my slideshow there, and we'll probably revisit some of these things in questions.
Thank you very much, Danny. Thank you for the fantastic talk. I think Mary is going to introduce our second speaker of this session, and then we'll have the Q&A at the end, as we did last time. Mary, are you there?
Yes, I'm there. Yes, thank you, Danny. It was very, very interesting what you just told. I would like to introduce the final speaker, Dr. Rania Koltsida from the Sortia Hospital in Athens, who would like to be able to talk about long COVID rehabilitation center that she is running.
Well, good afternoon to everyone. Thank you for being here and joining us online. My name is Rania Koltsida. I'm a respiratory physician working in Sotiria Chest Diseases Hospital in Athens, Greece. I would like to thank the organizing committee for the kind invitation. I've been involved with COVID-19 patients since the pandemic started in Athens, and I'm in charge of the outpatient clinic for post-COVID-19 patients. And recently we have organized a pulmonary rehabilitation program for all these patients. Within the next few minutes, I'll try to explain what is pulmonary rehabilitation and why post-COVID-19 patients need it. First of all, pulmonary rehabilitation is a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies, which include exercise training, education, and behavior change. It is designed to improve the physical and psychological condition of people with chronic respiratory diseases and promotes the long-term adherence of health-enhancing behaviors. The components of pulmonary rehabilitation are general exercise training, breathing training, and secretion clearance techniques. It also contains psychological support and patients' education, self-management. It includes nutritional advice, often smoking cessation, and of course, patient outcome assessment. So the main goals of pulmonary rehabilitation is to improve the body composition, increase physical activity, and promote mental health. It also helps to manage acute dyspnea, minimize everyday symptoms, detect and manage acute flare-ups of the disease, optimize pharmacotherapy, and also it facilitates smoking cessation and helps to establish social networking. When we talk about pulmonary rehabilitation, we need a multidisciplinary team consist of pulmonologists, physical medicine specialists, social workers, psychologists, nurses, respiratory therapists, occupational therapists, physiotherapists, general practitioners, pharmacists, and dietitians. And the benefits of pulmonary rehabilitation is, first of all, to minimize symptoms, reduce the intensity of breathlessness and lung discomfort, to improve muscle strength and patients' endurance, maximize patients' exercise performance, increase physical activity. It also enhances confidence, knowledge, increases patients' participation in everyday life activity. It also reduces anxiety and depression, and it helps to improve the psychological well-being of the patient. Finally, it improves health, quality of life, and increases survival. So, taking into account all the above mentioned, I'll try to explain why pulmonary rehabilitation is needed for post-COVID-19 patients. As you already heard, COVID-19 pandemic has created serious problems for global health and various types of complications and levels of functional impairment in millions of individuals recovering from the disease. As you already heard, post-COVID-19 patients suffer from symptoms such as fatigue, weakness, even a year after. They also complain of shortness of breath, dyspnea, cough, joint pain, chest pain. They have heart palpitations. They have problems with concentration and memory loss. Some of them complain of muscle pain, headaches. They sometimes feeling sick. They have loss of appetite, loss of smell, and many of them have problems with sleeping, and depression or anxiety because of the post-traumatic stress. So the aim of post-COVID rehabilitation is to support a full recovery, to support symptom management, and to support a return to normal life. So when to start the program? As an outpatient, this is for patients with mild disease. As an inpatient, during hospitalization, even start in the ICU setting, and post-hospitalization, 6 to 8 months weeks after discharge. And where to start the program? As I already told you, rehabilitation starts within the hospital, within the ICU setting, or it's for outpatients 6 to 8 weeks after discharge, or there are some home-based programs for patients that that are not able to go to the hospital to have the session. Clinicians should be very careful with patients' evaluation before starting a pulmonary rehabilitation program. They need to assess the need for oxygen at rest and physical exertion, the dyspnea level, and also assess patients' physical, cognitive, and emotional status. They need to test peripheral muscle strength and also assess respiratory function by using spirometry. They need to check for heart problems and also assess patients' nutritional needs and be very careful with comorbidities. Clinicians also follow preventive measures, wearing the appropriate personal protective equipment according to local policy. And rehabilitation treatment plans should be individualized, as I already told you, according to the patient's needs and taking into consideration their comorbidities. Rehabilitation should be aimed at relieving symptoms of homelessness, minimize everyday symptoms, and improve patients' health and functionality. Patients should be reviewed through the rehabilitation process before and after. They should receive education about their condition. We need to explain how to manage recovery, how to manage their everyday symptoms. Programs usually start 6 to 8 weeks post-discharge and last for about 6 to 9 weeks. Patients come to the hospital 2 to 3 times a week, and sessions usually last 1.5 to 2 hours. We start with low-intensity exercise, particularly for patients who still require oxygen therapy, while we carefully monitor vital signs, heart rate, pulse oximetry, and blood pressure. And we gradually increase the intensity of exercise based on patient symptoms. And the programs recommend that patients should have a frequency of 3 to 4 times a week, program for at least 45 minutes per session. And the exercise type includes walking, biking, muscle strength exercises for upper and lower extremities. It also includes airway clearing and breathing exercises such as diaphragmatic breathing, pursed lip breathing, and active abnormal contraction. Don't forget to educate patients, educate them about the clinical course of the disease, encourage lifestyle changes like adequate sleep, hydration, and proper nutrition. And also, it's very important to the psychological intervention to counsel about social support and also psychiatric consultation. Where in Soteria Hospital, we organized a pulmonary rehabilitation program. We recruited first group of 15 patients post-COVID, 5 male and 10 female, aged 42 to 65 years old. All patients were hospitalized in the second pulmonary department of Soteria Regional Chest Disease Hospital in Athens, Greece, during February and March 2021. They were all critically ill. They suffered from respiratory failure during their hospitalization, and they had lung infiltrates in the CT scan. All of them complained about fatigue, breathlessness, palpitations, muscle weakness, inability to work and concentrate, and lots of them had anxiety and depression due to post-traumatic stress 8 to 12 weeks after discharge. The duration of the program is 8 weeks. Patients come 2 times a week, and the session lasts for 1.5 hours. It contains supervised exercise training, breathing rehabilitation, and airway clearance. And the program also includes dietary consultation, psychological support, patient education, cardio function tests, and follow-up with CT scans, chest CT scans. And all patients underwent the primary evaluation, included dyspnea scale. We checked blood gases, lung function by spirometry. We also did 6-minute walk tests, sit-to stand tests, and blood tests to check thyroid function. We checked whether there were heart problems, and also we use quality of life questionnaires, quality of sleep, and post-traumatic stress questionnaires. So our patients will finish the program in July 15th, and all of them undergo all the tests included in the primary evaluation. I can assure you that already all of them feel much better. Their dyspnea and fatigue have decreased. They are more self-confident and have less anxiety. All of them made lifetime changes. They started workout, and they are more active in their daily activities. So in conclusion, pulmonary rehabilitation is one of the most effective management strategies to improve shortness of breath, to minimize everyday symptoms, to improve health status and exercise tolerance of patients with pulmonary disease, and for patients with post-COVID-19 symptoms. So I believe with proper measures and the immunization, we will be able to overcome this pandemic and its consequences. Let's all hope for the best. Thank you very much for your attention, and enjoy your summer holidays. Thank you very much.
Thank you very much, Rania. That's a really lovely presentation, and also a really encouraging message to finish with, to hear that so many patients benefited from the pulmonary rehabilitation exercise. As respiratory physicians, and obviously as the European Lung Foundation, we come from a respiratory background. We're used to pulmonary rehabilitation being the best possible treatment for a lot of respiratory conditions like COPD or interstitial lung disease, for example. And so I'm not surprised to hear really encouraging results early on, also for patients with long COVID. So we're going to move now into the final Q&A session, which is going to be focused on treatments. I'm going to welcome back Danny. We're going to welcome back Marianne, and we're going to welcome back Betty as well, if Betty's still there. So we'll now go to the audience's questions. Please keep asking your questions through the Q&A function, and we'll try to get to as many of these questions as we possibly can in this final session on treatment. I'm going to take Chair's prerogative to ask the first one, though, because I'm really interested, Danny, in what you said about autoimmunity, and could COVID be an autoimmune disease? Am I wrong to think that what Betty presented, that the most common age group is middle-aged and the most common patients are female, that's also the age and gender of patients that also are more likely to have autoimmune disease? If that's the case, is there data showing that the sort of phenotype, the immunology, is similar between autoimmune diseases and COVID?
Yeah, no, I think it's a really helpful point, isn't it? Because autoimmunity is much more common in most cases in women than in men, and that's never been entirely perfectly pinned down. But it wouldn't take a genius to work out that's to do with hormonal differences in impacting development of the immune system. And so if you try and join up the dots between that and our discussion today, we're part of the way there, aren't we? Because lots and lots of observations on how COVID infection per se leads to new patterns of autoimmunity, including those kind of pictures I showed. And some really impressive data, for example, showing how people who've had COVID have lots of antibodies against proteins in their skin. And you'd love to be able to say, what does that have to do with the rashes that people see in long COVID? So the final bit of that circle hasn't been squared yet, but I think it will be soon, and I think that'll be really helpful.
Yeah. So this is a follow-up to that, would be obvious for a lot of autoimmune diseases. What we do is we suppress the immune system with things like steroids. and we started using steroids in the middle of last year as a treatment for COVID. Question Danny first, and then maybe Betty as well. Is there any evidence so far that as the pandemic's gone on and we've used more drugs that suppress the immune system, we've seen less long COVID, or it's had any impact on long COVID?
I'd be keen to what Betty thinks. I don't think I've seen or heard of any evidence like that. And yeah, you know, and or even just that steroids, sure, but even the aggressive use of antivirals could have had some impact on long COVID. And I don't think I've seen evidence for that yet either, but I'd be keen to hear any other evidence. But you know, I was being a bit coy talking about the toolkit and the goodies on the shelf, but there is an awful lot of stuff out there apart from just steroids, if we only knew which stuff to try and put into proper trials, and that's getting closer.
So I can add to that. So there aren't any evidence from the recovery trial investigators, as Danny quite rightly pointed out. And I think that'll be really valuable because they have a really rich resource there. But we do have some data from the FOSS-COVID consortium. So the FOSS-COVID group of investigators have put out the first paper on 1,000 patients across the UK, and they did not find an association between the use of steroid and recovery. And recovery is defined by very subjective, like how the patient feels from a symptom perspective. So that was quite interesting.
Yeah. So a lot of our patients are looking for kind of practical tips about what they can do over the next few months with their symptoms. So I'll start with you, Rania. So you showed the nice rehabilitation program that you've got. A lot of our patients will live in places where they can't access rehabilitation programs like that, or they haven't been referred. Are there things that patients could just be doing themselves that could try to at least mimic some aspects of the program you've described?
Yes, of course. We advise all patients start even, walking outside, minimal exercise with safety. Unfortunately, patients that need oxygen therapy after discharge, it's not safe to start something like that. They need respiratory physician consultation, pulmonary consultation, and so it's difficult for them to exercise. But for patients that were not hospitalized and they still feel they complain about fatigue and dyspnea on exertion, they can start exercise, let's say for about 10 to 20 minutes a day, and gradually increase time and intensity.
Yeah, and if patients do experience that sense of real exhaustion, hours after or the day after exercise, what's your advice? Should you try and exercise through the fatigue, or should you rest? That's a really common question we get.
You need to follow them up. You need a CT scan to check if the infiltrates are still there. Maybe you need a spirometry to check their lung function, and also you need cardiological evaluation, because some of them suffer from myocarditis. It was not diagnosed during the hospitalization. And also you have to be very careful with the patients that suffered from pulmonary embolism or deep vein thrombosis during hospitalization. You need to be very careful with those patients too.
Yeah, so that's coming also through in the Q&A and in the chat. Some patients saying I've been diagnosed with myocarditis, some saying I've had a pulmonary embolism, but an awful lot of patients saying, sort of as going back to Danny's analogy, they've just had the consultation with somebody who said you've had long COVID, but they've not necessarily had many tests. And so it seems to be quite inconsistent. Maybe a view from everybody on the panel on how patients can access testing, or what kind of tests people should be expecting. Maybe start with... Yeah, go, Rania.
We follow patients to the outpatient clinic, and we actually have a protocol. We see them within a month after discharge, and all of them have blood tests, a CT scan within the 4 to 6 months, a spirometry if they still feel dyspnea And also they have blood tests and an echocardiogram. And actually, we detect problems. Yeah, patients that still have symptoms, they end up with problems.
And maybe Betty, do you want to expand on that in terms of testing?
Yeah, thanks, James. So, I mean, I think this is quite a complex question because in some ways it really comes down to a balance between benefits to patients from doing the investigation and the costs of the investigation. So if I were given, you know, an unlimited well of money, sure, I'd do all my fancy investigations. But I think from a primary healthcare perspective, I'd hope that there's at least sort of some basic screening test that gets done to exclude the more major complications. So, you know, for instance, cognitive assessment, ECG, 12-lead ECG, and someone who's complaining of palpitations or chest pain, some basics or even blood tests to look for troponin and BNP, some basic investigations at the GP level. And should any of them be abnormal, then you know, you're quite sure that this is actionable and it needs to be referred on to a specialty service. Now, if I had all the money in the world, I'd do my multi-organ scan on everyone and look for, you know, look to see if there's something that could explain it, because, you know, I'd like some answers. I need some tangible, you know, outcomes. I need to see what's going on. And so, yeah, that's really how I'd manage it if it was up to me entirely, and if I had all the money in the world. But neither is the case right now. So.
Yeah, I mean, I think it is an important point. Danny's slide about, you know, we're potentially making 10 to 20,000 long COVID patients a day in the UK. We don't have enough scanners to scan that many patients. We cannot scan 10,000 patients a day, so we do need investigations that are practical. Another set of questions that's coming through a lot is around the brain fog and how to cope with that. I think that's difficult, obviously, because we don't have trials. But Marianne, you mentioned that that's something that you've experienced. How have you coped with and managed that as a symptom?
Well, I still have it. So, and now I'm completely exhausted. So I will rest the next couple of days. But so what I do is, what I find is easier for me is when I started doing breathing exercises. And then I take cold showers. That has lifted my mood, that has lifted my clearance. I get still quickly exhausted, but still that is what I try to do. Even if I do, I did some push-ups for a period. Just before I went to bed, I did some breathing exercise and I could do push-ups. Before I got ill, I did 40 push-ups and like around 6 to 7 chin-ups. So I was fairly strong. Now I try to do for 5. And then before I did the breathing exercise, first I did the breathing exercise and then I could do this without anything. But then for me, this illness goes up and down. So I cannot give a clear answer on the brain fog. But I still try to do some brain tasks to keep the brain active. But yeah.
Yeah, and I'm curious, Rania, whether you've seen with some of your patients that your program is helping with the neurological symptoms as well as the physical limitation.
Actually, to that program, patients didn't refer any neurological signs. Most of them complained of fatigue and dyspnea on exertion, and they had problems, you know, to concentrate and to be able to work, actually. So the exercise and the breathing exercises help them, and also the psychological support help them to just overcome this post-traumatic stress.
Yeah. So a lot of the problems that we're having in answering the questions about what to do is we just don't have enough data. So, and it's very difficult for doctors to make a really firm recommendation when we don't know what causes something. Or Danny, because I know you've written about this in various forms, how do we as clinicians cope with uncertainty? So when we don't know the answer, and there's a lot of anecdotal evidence around, how do we help people? Because we really want to help people, but we don't always know the right answer.
Yeah, no, really, really important question. So The first thing to say is that things in time of COVID have moved forward really, really fast, and there's a real will to foreshorten all of these debates, and do things that used to be done in 6 years and get them done in 6 months. And the secret is just all of the obvious, isn't it? It still puts pressure, I'm afraid, on the patient groups, because they've really led the way. So they have to continue to be demanding and to press the point and press the demands and press the referrals. And then the doctor needs to listen, and we need to design the right trials to actually investigate our hypotheses and get the answers they need. It's all of the obvious, but just done at warp speed.
Yeah. And also being brave enough to say when we don't know.
Yeah.
Betty, anything to add to that?
No, I think everyone's essentially read my mind. These are all very important discussion points that will continue to evolve over time.
Yeah, so we've only got a couple of minutes left before the end. And so I want to go round and just give everybody a chance to give their kind of top tip, or what I would do over the next few months, either advice to the patients that are listening, or we've got a lot of healthcare professionals, what should we be focusing on, what should we be researching. So I'll go in the order that you appear on my screen. So starting with Rania, what do you want people to really take away today?
We don't have still all the answers, but we will be soon. And I hope we will overcome this pandemic and its consequences. And as a clinician, I encourage my patients, to stay calm and to be productive and to start be active and live their life. They should be lucky that they survived all this, so they should do their best to come back to their life and their families.
Okay. And Marianne, anything else you'd like to say to your fellow patients or to the clinicians that are listening?
I would just say for the long haulers like me, that the breathing techniques, I think, and the cold shower is good, and still try to do something good for your brain. I do meditate, but I'm starting to be a little bit sort of impatient for this, because here in Denmark they say that you should rest, and I'm tired of resting, to be honest. So the breathing techniques and the cold showers.
Great, thank you. Danny?
Yeah, no, all I'd add is I'd like people to try and keep up their optimism, because I do think that there are answers on the way. Honestly, I think all the right things are being done, and I think there will be diagnostics soon, and there will be therapeutics soon. And all you can do in the meantime, I think, is to continue to be a very demanding patient who really irritates your doctors and irritates your policymakers to make your demands, because how else are you going to be heard?
That's permission from Professor Altmann of Imperial College to be as irritating as you like. Betty, final word.
Yeah, so I mean, I was going to say exactly that. I think we've learned a lot from this session, just as much as the patients have, and and physicians managing them. And I really think that such forums where we're able to interact with each other and share our concerns, and be honest about what we don't know, and where we need to channel our funds and our energies and minds to answering. So I think this was a really, really exceptional session for me, and it's definitely reframed a lot of my questions. And I'm really determined to continue researching and continue trying to answer many of these questions and keeping an open mind about long COVID.
Yeah, and I think that's absolutely terrific. I sort of said that would be the last word, but a couple of further questions have come in that have really sort of piqued my interest. So I'm going to ask you a couple more questions, if I may. A few people asking, what are the parallels between long COVID and chronic fatigue syndrome, or ME? And is there anything we can learn about treatments of those conditions that we could apply to long COVID? Or in the reverse, a bit like the sort of analogies between COVID and flu, can it sometimes be a little bit dangerous to try and relate one disease to something else? I'll go in reverse order, so give that one to you first, Betty.
Sure. So, I mean, so people who've had chronic fatigue syndrome say that when they look at or listen to others who've now been diagnosed with long COVID, that they're basically looking at someone exactly like them, so someone in the mirror. And the point they're trying to make here is that there are a lot of symptoms in common, but there have been some reports where there are some symptoms that seem to be more prevalent or more dominant among long COVID patients. One of them is brain fog. And so I suspect what's going to happen is that among patients who have long COVID, there will be a subset, fairly large subset, in whom there will be quite a bit of overlap with chronic fatigue or CFS, and you know, they might end up having similar sort of treatment options. Now, what are the treatment options? I have to say, I'm not an expert in CFS, so I can't answer that question. But there are therapies out there that are being tested and trialed. Exercise is controversial, but that's where I'll stop for that answer.
Yeah, and I'll give the same from an immunology slant, Danny, to you. Is it a good idea to use analogies? It might be lupus or CFS or Epstein-Barr, or potentially misleading?
No, I think it's definitely helpful and useful. I get asked a lot about chronic fatigue syndrome, and my answer is always a bit unsatisfying. It's a kind of Rosetta Stone answer that I don't understand one, and I also don't understand the other. But I hope that by understanding a little bit of both, I can kind of, maybe do some decoding.
Yeah. That's. Do we know anything about the immunology of CFS? Like Betty, I'm not an expert on this.
Not much, not enough, and not much.
Yeah. So it emphasizes yet again this key point about doing the research and doing it rapidly and at scale. So I think we'll wrap things up there, because I think that's a nice point to end on in terms of we've had a fantastic day. We've had 3 sessions addressing different aspects of long COVID. We've talked about what it is. We've talked about what research needs to be done. And now we've talked about treatment, both in terms of what we do know, what we don't know, what we need to know going forward. I think some of my takeaways today, a lot of it is stating the obvious, but it's to say this is a really big problem. And I don't think internationally policymakers have necessarily grasped just what a big problem this is. The fact that we had 1,600 registrations for this conference tells you that there's a lot of patients with long COVID, and there's a lot of healthcare professionals with great information needs around how to manage long COVID. I think that's a really important takeaway message from today. We've learned that it's a very diverse condition, that patients have many different symptoms. Fatigue is the dominant symptom, but you'll remember from the first session that the number of symptoms couldn't be fitted onto one slide. It's such a diverse condition. And Danny reminded us very nicely of in medicine we have lumpers and splitters, and just because there's different patients with different characteristics doesn't mean that it isn't the same condition, and that the treatment may not be very similar for all of these different types of patients. We've heard really powerful stories from patients today, the videos that we've had of both their challenges in getting diagnosis and being understood and finding the right treatments. And that's going to be difficult for people all over the world because our healthcare systems work differently. Even within the UK, we have long COVID clinics in England, but not in Scotland. And so when we take into account that we have registrations today from 100 countries, how care is delivered in those countries is going to be very different for people with long COVID. And so as well as finding treatments for this condition, we also have to think about what's the best way to deliver that care. And Rania's talk was one example of a successful way of delivering a rehabilitation program to patients. But we will have to find best way to treat patients in our own healthcare systems in our own way, and cope with the scale of the number of patients that we're going to see with this problem, because so many people have had COVID. We now know that a lot of patients are going to have long COVID. The final message is one of hope. We haven't been able to give you the magic cure for long COVID today. None of you came to this conference expecting we'd be able to do that. But I hope we've given you information that's useful to manage your condition on a day-to-day basis, or to manage your patients if you're a healthcare professional. But most importantly, I hope that we've shown you that researchers all over the world are working day and night to try and understand this disease, to try and find the mechanisms, what's causing it, because once you understand something, you can treat it properly. And we're very close, as all of our speakers said, to having treatments both from a rehabilitation perspective, but also potentially from a pharmacotherapy perspective, to be able to offer to patients to make them feel better and to reduce the burden of long COVID. So the final message is we will get there. We will find a way to mitigate this problem and to help our patients. I hope the day has been educational. I hope it's been interesting. And I hope for the patients that are listening that it's given you some hope and some relief, and that you'll take away from today messages that are really helpful for your life going forward. So thank you. I want to finish by saying thank you to the European Lung Foundation and to Dragon, who organised today, both organisations that are really committed to engaging with patients and to bringing patients and clinicians together. Thank you to the technical team in the background who have kept things running. And thank you also to Marianne, who co-chaired with me through the whole day, and to Danny, who chaired the second session. It's been a fantastic team effort to deliver this conference today. And again, I hope you found it valuable, and have a wonderful Saturday. Bye-bye.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye.